If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Rick Abramson, welcome to Health Further. Excited to have you on. We have been digging into AI related to healthcare and generally following AI probably for a year and a half when it first started coming out. And excited to talk through this with you because you've really been at the forefront of AI even before any of us were paying attention. And so maybe let's start off by giving a little bit of your background. You've had a pretty diverse career. You're an MD, Harvard Medical School, but then you've had a quite diverse career in different areas, consulting, nonprofit, for-profit, startups. Give the audience a little bit about your background.
Yeah, sure thing. Thanks for having me, Vic and Marcus. Been looking forward to this for a long time. So let me just start off by saying that I consider myself a healthcare generalist. And I say that because over the years, I've acquired a pretty deep but pretty niche experience in this whole area of AI in medical imaging. But I'm here out of the conviction that despite the kind of niche aspect of this expertise, I think there's lessons to be learned that can apply across the whole healthcare ecosystem. And obviously, there's the listeners to this pod kind of span that ecosystem. And so over the conversation, I think let's try to draw out those lessons as much as we can. So as far as my background goes, I have kind of this kind of checkered past as kind of clinician and non-clinician, kind of hopping back and forth over the divide between the clinical and non-clinical parts of the healthcare realm. Trained as a physician, in particular a radiologist. So I'm a board certified radiologist and spent about 15 years in clinical practice, including 10 years at Vanderbilt on faculty here in Nashville. But to your point, also had a lot of experiences over on the non-clinical side. I actually started my career in the policy and health services research area. Did a stint at the White House doing Medicare analysis. Put in my time with McKinsey and Company as a consultant. And then later on, here in Nashville, served a couple of years in an executive role at HCA before jumping over into this AI world, where I've been for the past 3 or 4 years. And since I think we're probably going to focus a lot on AI, let me just tell you real quick about kind of what that last jump was like and what motivated it. So sitting over at HCA, doing this physician executive role, kind of have a bird's eye view of what's going on across the landscape, across all the HCA hospitals. And I'm recognizing there's some problems emerging. I'm seeing procedure volumes going through the roof. I'm seeing the workload increasing on providers. In the meantime, I'm also seeing the supply of providers, the physician supply, remaining the same or even going down, which means the workload on any individual provider is increasing astronomically. And what happens? Well, physician morale goes down, becomes harder to maintain quality, and we need a solution. And so, like others, I started looking around and looking to technology as potentially providing the solution to all those problems at the same time. And that was really kind of the genesis for my really kind of wanting to do a deep dive and a real immersion into the AI world. And that's kind of what led to my jumping ship and kind of joining the AI startup revolution over the past 3 or 4 years. First with a company called Covera outside of New York that is using AI working with payers, and then subsequently with a company called Annalise.ai, which is out of Sydney, Australia, that's developing advanced AI solutions for medical imaging. So that's kind of like the foundation. And learned a lot, and had been able to kind of look at this area from a bunch of different vantage points, and looking forward to kind of getting into it as we talk.
Yeah, I want to dive into radiology as a specialty because I think it's pretty interesting. Radiology was one of the earliest adopters of technology, all the way back to X-rays, but then more recently, MRI and PET scan, CT. And then even with workforce shifting with the night reads across the other side of the globe, Is that a proper frame of reference where radiology has really been an early adopter of technology and sort of workforce optimization? Or how do you think about that?
Yeah, I mean, I think it's a great way to frame it. And look, I look at radiology in some sense as kind of a bellwether field, kind of leading the way, and in some ways, kind of forecasting what's going to happen in other clinical domains. To your point, this is kind of the story of radiology has been one of progressive evolution and very quick technological evolution over the past 120 years. Starting in 1895, when this German scientist Wilhelm Röntgen was playing around in his laboratory and found out that there was a piece of barium-coated screen that was fluorescing on one side of his laboratory, and decided that, oh, hey, there must be some mysterious rays emanating from this cathode ray tube that I'm playing around with. And since he didn't know what they were up to, he would call them X-rays. And that's kind of how the profession got its started. And all of a sudden, we have this whole new medical field that progressed very, very rapidly. X-rays, and then fluoroscopy, and then ultrasound, and MRI, and CT, and nuclear medicine. And the history of this field, it's been very interesting. If you kind of look back, it's been one of successive technological innovation, kind of game-changing innovation every 10 or 15 years, kind of a new way of imaging the human body, until around 1980, 1990. And around 1980 and 90, that sequence continued. It was still a big shift every 10 or 15 years, but this time, instead of a shift in the way we image the human body, the shift started becoming the way we manage information and the way we archive and store information. And so 80s and 90s, you saw the advent of this thing called PACS, stand for Picture Archiving Communication System, is these big consoles that radiologists now stare at all day in a dark room. That replaced film. And that was a huge revolution. If you think about it, I mean, like the entire film industry disappeared over a matter of like a year or two. All of a sudden, instead of printing out X-rays on film, you're looking at them on a computer monitor, and that's the way it's been, for the past 30, 40 years. And then 10, 15 years later, all of a sudden, you've got this new advent called teleradiology, where you can transmit images for remote interpretation somewhere else other than when they were acquired. This is something that would not have been possible before high bandwidth internet. And again, sudden transformative change in how the field is practiced. That was kind of in the mid 2000s. And now I would argue we're in the middle of the next incremental wave of transformation. So I think the next 10, 15 years have passed since teleradiology, and now we're firmly in the revolution of AI. And we're kind of building the airplane as we fly it, but I think it's already beginning to dramatically change the field, and I think it will continue to do so over the next couple of years.
Can I ask a quick question before we continue on? Rick, what do you think is special about radiology, where the clinicians are embracing technological advancement at the rate of every 10 to 15 years, and maybe now it's getting into less than 10 years, but that's something that we always talk about as investors, the rate of change that clinicians are willing to adopt. And it seems like in radiology, it's advanced beyond what other specialties or primary care is willing to accept in terms of step changes. So is there anything about radiology, just from a mindset about the practice itself, that leads to a different sort of culture there in terms of the willingness to embrace change?
Yeah, it's a really interesting question, Marcus, and I think it's multifactorial. I think there is a cultural aspect there. I think that for whatever reason, whether the field creates physicians who are more amenable to change, or whether the physicians that happen to go into radiology are more innovative or more progressive or more change-minded, I'm not sure, but there is that cultural element. And look, radiologists, if you kind of survey radiologists, they're very proud of that. They're kind of very proud of it being at the vanguard of technological change. It's kind of like a core identity among radiology. But I think there's other aspects too. A lot of research funding over the years has gone into medical imaging, and some of it is derived from there's research into like military spending imaging in World War II eventually kind of found its way into medical imaging applications, right? And so I think radiology has been the beneficiary of a lot of scientific research advancement. And then I think the final thing, honestly, is just economic and kind of in competition and entrepreneurship. And I think the recognition among radiologists that if they don't stay on the forefront of technological advancement, they're going to get left behind. One thing about medical imaging is it is always embroiled in turf wars with other specialties. And so, radiologists, the clinicians, kind of the clinician listeners, I think will know what I'm talking about. The radiologists are always fighting it out with cardiology and with OBGYN and with vascular surgery. And there's always, everybody's kind of fighting it out for the more lucrative procedures and for the volumes. And I think radiologists know that if they're not constantly advancing the field, they're going to be obsolete.
Yeah. So I'm interested, building on that, radiologists, I think, have a really interesting role in kind of interpreting the images for the other doc who's delivering care. And there's something around that partnership. The radiologist needs to keep extending, keep getting more and more at the frontier of new technology tools to advise the cardiologist or an internal surgeon or whatever the other practices are, orthopedic. They could do it themselves, but they would probably miss some things on the images. But if it's a very standard image, X-ray, maybe they can look at that. Maybe a more complicated image, they need the true expert, the radiologist, to help translate. Is that fair, or do you think that's a mischaracterization?
I think it's fair. I think it's also something that's changing, and I think this is actually a conversation that's really going to come into the forefront with the AI revolution, right? Because now we're talking about software applications that could potentially read the image for you, or if not completely read the image for you, then certainly help you read the image and help you avoid errors and mistakes, and potentially expedite the speed with which you come up with diagnoses. And so there's a lot of talk about using AI technology to empower non-radiologist physicians, and for that matter, even just non-physicians, to render diagnoses. And so, whereas once before it was all the radiologist purview, now you're talking about using AI software to empower ED physicians or ICU physicians, or potentially to empower physician assistants or nurse practitioners, especially in underserved areas of the globe that may suffer from a physician shortage. And so I think there's going to be a lot of disruption and a lot of conversations about professional identity coming up in the future. And again, this is one of these areas that's not specific to imaging. I think all throughout medicine, there's going to be a redefinition of kind of traditional physician and provider roles. And it's all enabled by technology. And it's all in service of this idea that you can automate certain functions and then potentially standardize and replace certain functions potentially with a lower cost labor input if you want to be very dry and economic about it. But it's also a matter of trying to augment quality as well through standardization and efficiency. And so everything is kind of, I think, on the table right now as we kind of sort through this whole emerging software revolution.
Yeah, excellent. So before we dig into the AI specifically, I'd like to get your perspective on large academic medical center like Vanderbilt versus a large for-profit health system, HCA, versus a U.S. VC-backed company versus a global company headquartered in Australia. Those are the last 4 jobs you have had, I think. How do those different enterprises think about new technology in general, and how do they function? What's the culture differences? Can you compare or contrast any of those?
Oh man, it's super interesting. Probably deserves a podcast of its own. I learned something from every stop I make. Which is what makes it so interesting. I'll take a shot at it from a very kind of high level. The academic centers that I've been at, and it's not just Vanderbilt. I've been at Johns Hopkins. I've been at up at University of Pennsylvania, up at Brigham and Women's Hospital up in Boston. These are serving kind of multiple missions at the same time. They're trying to deliver care, but they're also advancing research. A lot of academic medical centers are kind of interested in developing their own technologies, either for research purposes or potentially for commercial purposes as well. And I think that they've had mixed success in that area. There's some really great success stories of new technology spinning out from academia, as you know. There's also a lot of unfortunately kind of a history of creating solutions to problems that aren't really much of problems. If that makes sense. Elegant solutions to doing something that nobody really is bothered by in the first place. And so I think that I think that's a challenge that's faced by academic centers, but at the same time, they're serving an important role of furthering our basic knowledge, our basic understanding. And so I think that's something that every academic medical center wrestles with. HCA was an interesting experience, and I'm a couple years out at this point, but I can say that what was going on at HCA when I was there was HCA trying to figure out how to capitalize on this vast store of extremely valuable data that it was sitting on just as a large organization. And I think that's it's from an investment standpoint. I think that's actually an important kind of thing to underline, which is that scale has advantages other than just economic resource. Scale has data resources as well, and so there are certain things that an organization like HCA can do in terms of developing new applications and new solutions, just by virtue of its enormous size and enormous access to data, that a smaller institution could not do, even if it had the just bare economic resources to do it. Now, when I was at HCA, a lot of the focus was not on clinical AI, but rather on operational AI, if you will. So AI to kind of streamline operations in the hospitals, in the facilities, resource management, how to move patients through workflows, how to optimize care pathways, but not from a clinical standpoint, but rather a non-clinical standpoint. And that was really interesting for me to see, really something as an impartial observer to watch. And it made a lot of sense when I saw it happening, because it's an organization that is responsible to shareholders. It wants to capture efficiencies. It wants to kind of go after the low-hanging fruit. And this is something that's reflected in the larger market. So let me now kind of shift to the larger market and the startups and the kind of the VC-backed entities that you spoke of. When I look at AI, and this is beyond medical imaging, this is like all of kind of AI for healthcare. The first kind of branch point that I have when I kind of look at this universe is between clinical applications and non-clinical applications. And so, for us, in radiology, the clinical applications are that's the sexy stuff, right? That's like, oh, we're going to create a software that's going to read your X-ray. That's like, woo, everybody gets really excited about it. But any discussion of AI for medical imaging is woefully incomplete if you don't talk about AI for non-clinical aspects of imaging. And this is the boring stuff, and it's the non-sexy stuff, but it's actually really, really important. It's the prior authorization, and it's the scheduling, and it's the staffing, and it's the charge capture, and the revenue cycle management, and the business analytics, right? And obviously, you guys know this as investors, but a lot of people who don't think about this ecosystem, they automatically jump to the sexy stuff, and they forget like this huge value chain, that exists before and after the delivery of the actual clinical service. And that's actually where I think a lot of the attention is focused right now. So, in that VC startup world, a lot of the more successful entities that I've seen, and we'd be curious if this resonates with your experience as well. A lot of the more successful plays have been non-clinical in nature, going after the boring but really important stuff, and optimizing processes that are non-clinical, exempt from regulatory oversight, which is really important. We'll probably come back to that. And more importantly, stuff that's just really, it's dollars and cents. It's efficiency, it's operations, it's like the stuff, this block and tackle stuff that you have to kind of do. And it's a lot easier to accomplish than a lot of the more ambitious clinical stuff that we have going on. So like that's kind of how I'm looking at the ecosystem, and how I'm kind of looking at kind of like how these different entities have kind of approached the problem.
Yeah, I think that we have the exact same philosophy. I think there's sort of two different levels of adoption, maybe. And while it may be boring, it's about 20% of something like a $5 trillion annual spend. And so you're looking at about $1 trillion in overhead. So even the boring stuff can be a significant number of pennies there. But I think the natural place that is really impactful to care and also can be somewhat daunting and emotionally triggering to some folks, patients and doctors, is moving into the clinic, into actually the delivery of care, because that's the other 80%. So certainly the first movers and where a lot of the adoption has happened, where a lot of the venture money has gone, is in that first non-clinical revenue cycle, maybe helping with physician notes, all of that stuff that is adjacent to clinical. And I think there's a lot of patients, a lot of doctors that I think are excited about the AI opportunity in changing the way we care for patients. And there's other people that are nervous about that for privacy reasons and all kinds of reasons that we all understand. So I think it is important to differentiate that. Maybe give us a sense for what your view is in terms of, like, forget the regulatory apparatus, but just the pure technology capabilities today as it relates to radiology, or wherever you want to take it. Like, where is the state of the technology today if we didn't have to deal with regulation? Of course, we'll get to that in a minute. Just how functional is the technology as a radiologist looking into this stuff?
Yeah.
Where is it useful? Where is it not yet?
Yeah. Okay, so I'm bullish. Let's start there. I'm an optimist, and kind of coming out of this kind of immersive experience that I've had for the last 3 or 4 years. I think the technology is really good and it's getting better at a pretty good clip. And let me give some specifics, because it's easy to just kind of hand wave and say, like, oh, we're doing great things. But let me tell you kind of what I'm seeing across the globe. All right. So I'm seeing in medical imaging, I'm seeing software being deployed with a specific intention of catching errors and catching misses. Okay, and so these would be software for that would kind of scan an image as it's being interpreted by a radiologist, and say, hey, wait a second, radiologist, there might be a little spot on the lung that you may have missed. You may have neglected this little spot on the lung, and that actually might be an early lung cancer. So that's a very, very specific, concrete example of an application that we're seeing, and that's real world. Today, in 2024, we can actually do that. We can say, hey, look, there may be an early stroke that you neglected, that you missed, that you haven't picked up, a little hemorrhage in the brain that's going to dramatically change care for this emergency room patient. We're seeing that again. That's real world in 2024. We're seeing that in use right now. We're seeing technology that will flag urgent cases in the ER and pop those urgent cases up to the top of a work list so that they get interpreted sooner, communicated to the referring team sooner, and the care is initiated more quickly. That's real world right now. On the other end of the spectrum, as far as kind of like of care delivery, we're seeing AI being used to screen populations for infectious disease. We're seeing AI tools being deployed to screen for tuberculosis in developing countries. We're also seeing AI being used to screen and help screen for breast cancer, for example, and for screening mammography. We're seeing cases of AI being used to intelligently triage care to specialists. For example, this is something that should go to neurosurgery, and we're going to expedite that triage to neurosurgery. And we're just beginning to see AI being used to draft the reports for radiologists. And I put that in kind of a special category, and it might be something to come back to later, because this starts getting into the use of some of the more advanced general AI, like ChatGPT type technology, like these large language models. And there's been a lot of experimentation about kind of like whether these language models can be applied to radiology. I think the jury is still out, and for a bunch of reasons, I think it's a little bit premature to start thinking that ChatGPT is going to replace radiologists. But it's an example of what people are thinking about in terms of the technology. Now, one thing I will say, Vic, just to kind of answer your question and to kind of do it fairly, is to say that I'm giving examples that are kind of empiric in nature, right? And I'm just saying I can point to anecdotes of a missed lung cancer that AI caught, or a missed fracture that AI caught. But it's one thing to point to anecdotes; it's another to back up your statement with statistics, right? And I'd say that the clinical evidence for this stuff is here, it's present, but it's still somewhat rudimentary. And that's for a variety of reasons. We can measure the effect of AI on physician performance, but the data gets a little bit it's noisy, and it's a little bit nebulous. We need better trials, larger studies of the technology to make sure that we're not just relying on anecdotes and just one-off examples here and there. But I would say in my experience, I mean, I can certainly point to those anecdotal examples, and I can say that the models are only getting better and better.
Okay, excellent. And just to help me understand it, maybe help the listeners, are there a couple of different categories that you framed up using examples? So maybe a population being screened for tuberculosis in a developing world that we're not doing today, that now with these tools, they're lower cost, you could get screenings to areas that are not possible before. That seems like a pretty easy use case. Then the next one is modifying the triage, either how the images are read or pushing referrals to the right specialty. They were sort of an ED use case and then also a subspecialty referral. That's more of a, I don't know, triage appropriately, or use AI to organize the caseload more effectively. Again, that seems pretty straightforward. And then you start to get maybe a little more anecdotal, need to do more research on, which is finding a concerning spot in the image that maybe the human doctor didn't see. That could be really valuable, but maybe it is a false positive that is not. So that's maybe where there's a lot of promise, but it's hard to know the net effect over a large population without a study. So that's maybe another category. And then the last would be automating some of the physician's work, doing a report or so, which is the furthest unknown, but has a lot of potential. Is that a fair categorization of the different examples?
Yeah, no, I think that's a good way of breaking it out. You could even do it more simplistically, and you just talk about quality and efficiency as being kind of the two arms, the two levers that we're trying to move. With efficiency being both efficiency of care delivery and efficiency of physician work. But if you're kind of looking for, I mean, I'm anticipating kind of like the next step in the conversation, which is going to be about potentially about ROI. Those would be kind of like the very, very high level ROI levers that I think that we're trying to get at if you look at it kind of from a business model standpoint.
Right. And that's where some of the public health developing world, if someone's willing to pay for it, that's very good to bring more screenings to the developed world. The ROI is maybe not as carefully looked at because it's some nonprofit maybe that's trying to get better public health out there, which is probably different than how a health system would think about organizing their human talent to get the most efficiency out of the patient population.
Yeah. The whole conversation is tied into the question of just kind of business model development and who is the ultimate customer. And that in itself is something that the AI industry I think is still wrestling with, kind of defining on a very, very fundamental level, who is the ultimate customer in all this. I mean, the ultimate customer is the patient, right? But I mean, in terms of who's writing the check, who's kind of funding this development? Is it the provider? Is it the hospital? Is it government? Is it non-government organizations? Is it pharma? There's kind of like you can kind of think about there's actually there's stuff going on right now where pharma is being leveraged in service of global health, right? Because like pharma wants to get out drugs for early lung cancer, and so they're potentially funding AI for use in a large scale global public health initiative. But instead of funding it through an NGO or through the World Health Organization, it's actually funded by private pharma. So that's a model. Payers is another potential customer. And so there's kind of different value narratives associated with different customers, and we're so early in this industry that I can tell you all of these models are still on the table and they're still being explored. And I don't think we've nailed down yet what the ultimate model is going to be.
Yeah.
Just more of a question around what it's like to be, an executive with a fair amount of experience in this industry who was watching AI before LLMs came around. I heard you say LLMs replacing radiologists probably a little bit premature, and I think we've all got the question around when hallucinations are going to get to a place where we're all a lot more comfortable about handing over the keys to these machines, which, by the way, none of us know how they actually work. Not even the people who've created the transformers can actually explain how they work on the inside. It sounds like when you talked about your different anecdotes of where AI is making an impact today in patients' lives, that those were not LLM examples. They were more sort of machine learning examples, which was kind of what we used to talk about when we talked about AI before Sam Altman came on the scene. So I'm just sort of wondering, now that AI has largely become synonymous with LLMs since ChatGPT has broken out on the scene, how confusing is it for the general public as you are seeking to build relationships, build partnerships, talk with people who are not as deep in the space as you are, around what AI means in its broadest sense, and really in the areas where you believe it can truly create value today, versus LLMs, which hold unbelievable promise for the future, but today have a lot of barriers, to include a regulatory threshold when we're talking about them replacing clinicians?
Yeah, it's such a great question, and it's all wrapped up in this very, very intertangled story about regulatory, about ROI, about just how the general market understands the technology. So I mentioned before that when I look at the AI universe, I'm always kind of thinking in terms of clinical versus non-clinical. The other kind of big branch, categorization that I always do is between general AI and more narrow AI models. And that's exactly, I think, what you were referring to, right? In terms of kind of ChatGPT being the exemplar of a general AI tool. And then kind of what I've been talking about is more, very narrowly focused, specifically trained, more machine learning applications being more the narrow AI. And the conversation completely changed in November 22, is that when I think when ChatGPT was released, because up until then it was all just the narrow machine learning models, and now all of a sudden we've got this general intelligence, general large language model entity to deal with, and to ask how does this fit into the whole equation. For us in radiology, the ultimate application of the LLMs would be, as I said before, to draft the report. Now, why is that so important to radiology? Well, it's because the unit currency in radiology is really the report. I mean, that's the product. If you kind of think of it in terms of it in an industrial mindset, I mean, the end product that I create as a radiologist is a report. It's either a slip of paper or an electronic report, but it's electronic report and it's text. So, if you can get an LLM to generate that text, well, all of a sudden, that's a huge shift in my workflow and potentially an unbelievable shift in my efficiency as a producer. And the reason I say it's kind of wrapped up in the conversation around ROI is because, let's keep in mind that this technology, by and large, across the globe, is not yet reimbursed. This is not a reimbursed technology. There's no CPT codes. There's a couple of CPT codes here and there, but for the most part, this is not reimbursed. And so if I put on my sales hat and if I go to a hospital or radiology group, it's not a matter of just convincing them to adopt my technology. I have to get them to pay for it. I got to actually sell this technology to them. And, unfortunately or fortunately, depending on your perspective, quality improvement or quality maintenance in and of itself, it's hard to sell. It's hard to sell quality, especially in the United States, without an associated efficiency improvement. And so that efficiency gain becomes extremely, extremely important. Now, we have some data. I had some data from from my time at Annalise, suggesting that even these narrow machine learning tools may actually make radiologists more efficient, slightly more efficient. And when I say slightly, I mean maybe 10% more efficient, 15% more efficient, which is nothing to sneeze at. But then y'all have lunch with a friend of mine in private equity, and they say to me, we want to do a big roll up, and we're going to open up a can of AI. And just tell me, am I looking at like a 3x efficiency gain, 4x gain, 5x gain? I'm like, how about like a 1.1x gain? And then lunch is over pretty quickly, and then I have to get the bill. So it's an incremental improvement with these narrow tools, but with a general tool with ChatGPT, man, if these things are actually drafting the reports for me, and all I have to do is just glance at the image, glance at the report, make sure it's right, and sign off. I mean, wow, that's huge. I mean, now we are talking about 3x, 4x, 5x gains, and that's really gets people attention. The problem is, and you probably know this, the problem is these ChatGPT models, they're not just making up and fabricating references in college book reports, they're also hallucinating clinical findings as well. And I don't think anyone has yet been able to prove that these models can generate hallucination-free reports or fabrication-free reports at the level they would need to be in order to be incorporated into clinical workflows. Right. And so we're stuck for now. And I think the big debate going on in the academic circles and also in industry is whether, everybody wants to automate reports. It's like, how do we do it? Are we going to refine ChatGPT to do it? Or are we going to take one of these kind of more narrow machine learning approaches and kind of put some kind of text generation overlay on top of that? That's where that's really kind of bleeding edge, I think, in terms of the technology development. But that's the holy grail in radiology, is automating that report. And then again, okay, now let's open that back up, take it outside of radiology and look at all these other clinical disciplines. So we would ask ourselves, okay, what is the ultimate product? In urologic surgery, maybe the ultimate product is a prostatectomy. Okay, and so, we've got robots to do our prostatectomy. Great. How much of an efficiency improvement is that for our urologic surgeons? So you start using the same. I mean, not that ChatGPT is going to start doing robotic prostatectomies, but I mean, it's the same. I think like when we look at AI in terms of and ask ourselves whether AI is going to present enough of an ROI to promote large-scale adoption in absence of reimbursement, that's the kind of mentality I think we have to use. And it's a pretty high hurdle. It's a very high bar. And I think that's why a lot of clinical AI startups continue to struggle, because they're showing quality improvement, they're showing incremental efficiency improvement, just not enough to make the bean counter say like, okay, yeah, this is something we have to do. This is a must do rather than a nice to do.
Right.
Yeah. So that's where I was going to go next. Healthcare is, at least in the U.S., well, actually globally, highly regulated. It's regulated different ways based on the country. And I think the regulators, probably rightly, have a duty to ensure safety and reliability before they start sort of opening up the opportunity. What's your view of how AI, whether it's narrow AI or broader LLM, general AI, is regulated today? And then where do you see the regulation kind of going in the US and then globally?
Yeah. Okay. Well, so I'll start one more time with that clinical, non-clinical distinction. And that's important for regulatory, because if you can escape FDA regulation as a clinical device, your entire world is different. Your entire go-to-market, your entire sales and marketing strategy is completely different than if you're regulated as a clinical device. And I can point to several startups in my space whose entire business strategy revolves around making sure that they're not classified as a clinical medical device by the FDA. And so that's very important. I think just first to understand that, like, if you can be non-clinical, you're in a much different place than if you're clinical. Now, if you are clinical, you're regulated as a medical device. In the US, it would be by the FDA, and in Europe, it would be EMA with the CE mark. Australia, it's the TGA, the Therapeutic Goods Administration. In Japan, it's the PMDA. But it's all under the set of regulations that apply to medical devices. And so the same general outfit within the FDA that regulates cardiac defibrillators and catheters and tongue depressors. It's the same that same part of FDA that regulates AI. Now, FDA has been really scrambling the past several years to modernize its regulatory framework. My opinion right now, and I'll preface this by saying that I'm not a defund the FDA guy. Like, I don't want to blow up the FDA. I think the FDA serves an extremely, extremely important purpose. Making sure that the drugs and devices out on the market are safe and effective, and really, really safeguards the American consumer. With that as a preface, I think that the FDA, I think, is probably at this point overly stringent with its regulation of AI devices, and I think is impeding innovation and access to innovative products in the American marketplace. And I say that because I say that not without evidence to back it up. I mean, we can point empirically to approved AI devices in Europe and compare it to approved AI devices in America. And Europe leads the pack and is moving further and further away. In other words, there's a growing, I would call it, innovation gap between Europe and the U.S., and which means that European patients have access to more cutting edge products than American patients do. Now, that's obviously could be interpreted either way. I mean, you could interpret it that Europe has just gone off the rails and they're just approving stuff willy-nilly without proper evidence of efficacy and safety. I think a big difference is what Europe has done. Europe has adopted more of a mindset of get products out to market and then perform post-market surveillance to make sure that those products are safe and effective, and if not, remove them from the market. Whereas America, the FDA is doing the emphasis is more on pre-market evidence, and the evidentiary burden on developers trying to come into the U.S. is very high. So high, in fact, that you see a lot of companies global companies looking at the U.S. market, saying, "Great market. Would be so nice if I could get in, but it's just too expensive, and I'm just going to stay out of the U.S. market. I'm going to sell my products elsewhere. Either that, or I'm going to kind of sell some dumbed down version of my product into the U.S. Something that I know that I can get through regulatory, but not a product with the full functionality that I deploy elsewhere." Which is, again, like from my perspective, that's unfortunate. Others could look at that and say that that U.S. is being appropriately prudent and in terms of kind of having this higher level of these higher evidentiary standards. But look, the way I've come to look at this whole area, I kind of look at this, especially for medical imaging, but elsewhere as well. I look at AI primarily as a safety device. That's kind of like the paradigm that I've adopted. Going back to my empirical examples of AI, catching a missed lung cancer or catching a missed fracture or a missed stroke. I'm looking at AI primarily as a second pair of eyes for me because I'm stressed, I'm overworked, I have too many studies to read. AI is kind of like something that's operating in the background to make sure that I'm delivering high quality care. And in my mind, maybe it's because I have a teenager who just got his driver's license that I'm starting to think this way. But Alex, my 16-year-old, he's been driving now for a couple of months, and he's out on the road now with a bunch of really stressed out drivers who are, like the roads are busier now than ever before. It's very similar to kind of like the procedural environment in healthcare. I sleep a little bit better at night knowing that he's driving a car that's got like the little, the lane shift monitor and the blind spot protection and the little thing that beeps if he's going to back up into a fire hydrant, that type of thing. And I kind of think of AI for radiology in the same way, that I would actually sleep better as a radiologist and as a patient as well, knowing that they have these safety devices working in the background. And so for me, that means kind of a lower, slightly lower burden of clinical evidence, not dropping the burden entirely, but just making sure that regulatory burden is commensurate with the level of risk. And right now, I think it's disproportionate, and I think it's ready for a readjustment.
And where is the line in your mind? Is it that the doctor needs to make the diagnosis and care plan, and the AI should be a tool providing information or highlighting a part of the image, and that would be okay? Or is the line somewhere else? Like what needs to be approved differently versus what can be brought in under the existing regulations?
Yeah. So that's really interesting, because that gets it to this kind of like yet another taxonomy, right? Yet another way of categorizing these things. But if the AMA has actually come out with a framework. It's actually supposed to be used not so much for regulatory, but actually more for reimbursement. But they categorize these AI tools as assistive, augmentative, or autonomous. Okay, so assistive, as it implies, it's assisting the physician, but the physician is still in the driver's seat. It's kind of the physician's doing their job. It's just you get a little bit of AI help, on the side. Augmentative, the AI is actually, the physician's still in the driver's seat, but the AI is actually providing some information that the physician may not be able to generate him or herself. So might provide like a risk score, for example. That would be an example of something that if I'm just looking at a lung nodule, I can't say just with my own clinical knowledge the percentage chance of it being cancer. But if you have an algorithm that actually has a nomogram and refers to some clinical trial data and can actually say, it's a 63% chance of it being lung cancer, that would be that second category, augmentative, because it's providing some additional information that I wouldn't otherwise be able to generate. And the third category is probably the most interesting and the most vexing, for kind of like, just kind of thinking about things, is that autonomous AI, where the AI is actually replacing the physician and actually doing stuff like, as it implies, autonomously. Now, the fascinating thing to me, just when we talk about kind of learning in these different roles, as the chief medical officer for an AI company, one of the most fascinating learnings for me is that autonomous AI actually probably has an easier pathway than assistive AI, which was completely counterintuitive to me when I kind of first started wrestling with it, but now is starting to make a little bit more sense. This idea of physicians being assisted by AI gets you into a whole bunch of just metaphysical issues and philosophical issues about what the technology is doing to the physician. Is the technology augmenting the physician's judgment? Is it potentially biasing the physician's judgment? What are the fact we know that none of these AI tools are perfect, and so these false positives, these false negatives. It's a real conundrum of kind of thinking about okay, how is the physician as the primary operator transformed from not using the technology to working with the technology? And I don't think anybody has really kind of gotten their, kind of really wrapped their brain around all these implications, which is why I think all the regulators struggle with it. If you look at autonomous AI, though, that's actually a much simpler problem, because you don't have to look at the effect of the AI on a human operator. You just have to look at the AI's performance. And we have statistics to tell you that. I can tell you, like an autonomous mammography engine, I can run a very, very simple clinical trial and tell you the accuracy of that software tool for identifying a breast mass. But it's a lot harder to actually say, okay, if you have a mammographer using the tool, what are the effects of the tool on the mammographer? And so it's actually paradoxically, I think going to be easier to have autonomous tools get through regulatory and to get reimbursed than the assistive tools. Now, we're not ready for the autonomous tools yet, but when they get here, I think they may actually lap the assistive tools in terms of making their way to market.
That's
interesting. It is counterintuitive.
Yeah, and also not like the conversation we've been having in previous. We've had conversations with Tarun Kapoor, who's at Virtua Health. My friend Ambar Bhattacharya, he's a VC at Maverick. Talked to both of them, and they were sort of talking about the paradigm of co-pilot versus autopilot, right? And which is what you just sort of talked about. And generally speaking, we've been talking about how the public can better wrap their head around co-pilot than they can around autopilot, just because even if the outcome of the autopilot is better on the whole, the minute the autopilot fails, it's, the machine killed a person, right? And so you get into the whole kind of like Frankenstein chase him, over the hill kind of thing. But I think in a regulatory context, what you're saying does make some sense. And I think I think the other thing that's sort of corroborating your point is we are now having a very broad conversation about the ways in which technology is impacting humans from a mental health perspective, by way of our conversation about social media right now. Like we let social media run unfettered for basically a decade, before we actually stopped and said, hey, has anyone looked at this thing and studied it to see whether or not it's actually impairing the way we are thinking and feeling? And now that conversation is front and center, I think you're right. I think we're now going to be looking at the way that technology does influence people in all manners of life, and that's interesting.
Yeah, and I think it is. It just demonstrates the challenges that the regulatory people in these agencies have to wrestle with. Right, like it probably is an easier statistical challenge,
right,
to test the fully autonomous AI tool compared to the status quo. And at some level, it would be sufficiently good quality that it could be possible to allow it. And yet with your son and my driving and my son's, and we're all used to the co-pilot cruise control or the lane change, or, we fly on airlines and they all have autopilot. But there's a pilot sitting there to make sure they land and take off and everything if there's any problems. So the public perception and just like I think the human understanding of it seems more scary to be fully autonomous, but it probably is easier to control as a regulator. So you have this public perception versus the statistical analysis.
Yeah, and I do want to just reemphasize that I was really talking about regulatory and reimbursement, very narrow. Yeah, I completely agree that the larger market adoption, I mean, that significant headwinds, right, in terms of kind of public's willingness to endorse and adopt, the autopilot model for healthcare. Although, I mean, it would, maybe we should work on that, right? Because if you use the self-driving car as is always the analogy we go to. I mean, that imagine a world where it's all autonomous cars. I think that 45,000 deaths a year from car accidents, I think that number would be orders of magnitude lower, but it's not going to be zero. And I think to your point, the public is not going to tolerate those non-zero deaths from autonomous cars, even if it's like a huge public health benefit by making the shift.
Right, right.
Look to the future a little bit. I mean, you're in a startup. Talk about that technology that you're working with, but then also help us understand what should we be watching for in the next 3, 6, 12, 18 months? What are the big technical advances that you think could really unlock significant market opportunities? And you may be in one of them. So maybe Annalise.ai, probably not saying that right. How do you say the company?
Oh, Annalise.
Annalise.ai may be a poster child for that. You may be an example of that, but just give us the overall view of technology.
Sure, yeah. And I should say that I've actually pulled away from my full-time role at Annalise effective just a couple of weeks ago, just for other complex factors that we don't have to go into, mostly logistics around working for a company in Australia.
In Australia.
Yeah. I continue to serve them as a consultant, so I'm not fully away from them. But yeah. So okay, let me talk about I'll talk about radiology, but let me talk about the larger AI landscape as well. And again, I'd love to see if this how this dovetails with your experience as well, kind of talking to entrepreneurs. So I think the big next 12 to 18 months for for radiology medical imaging. There's going to be a lot more discussion around LLMs. So I think let's start there. It's not all going to be about drafting reports and how best to do it, whether to use these general large language models or more or kind of versions of narrow tailored machine learning. There is I think everyone is very much waiting to see if the FDA changes its approach to regulation, potentially after the November election. I think there's kind of a lot. There's going to be a lot of let's watch the FDA and see kind of what comes out. There's also a phenomenon that's kind of emerged over the past maybe 12 to 24 months called foundation models. And these exist not only obviously in imaging, but elsewhere as well. These foundation models, essentially, I think the best way I can describe them is to say that these are these large kind of pre-trained algorithms that are like 85% baked. They're kind of like 85% ready because they use these large data sets to make these really, really great models. But there's a little bit left undone so that you can come into a site, you can come into an HCA or a Tenet, or you can come into a Cleveland Clinic or whatever, and then you can train the rest of the model on local data from the system, with the idea that that model then kind of becomes more narrowly tailored to that site, to that system, potentially less biased because it kind of incorporates more local data, and it's also something that the site has some partial ownership over. So I think those are going to be very important, not just in medical imaging, but in other areas of kind of AI and data science and healthcare. And so I'm going to be watching that very carefully, both from a business perspective and also from a regulatory perspective as well, because it has some kind of there are some interesting intersections with the FDA apparatus there as well. And then I'll just try to kind of bring it outside of imaging. Everyone's very excited about AI in healthcare, especially for clinical use. But oftentimes there's a bunch, it's kind of vague. People say like, we're going to have these computational insights. And then it's kind of like, well, what are those computational insights? And so let me offer some areas that I think are interesting to me, and to see how these mesh with what you're seeing. So diagnostic medicine is the first area. So not only medical imaging, but also pathology and dermatology, any part of medicine that's kind of relies on visual pattern recognition, I think is very much amenable to these machine learning techniques. And I think can and will be exploited. The pathology, I think the rate limiting step is the adoption of digitization. But once we kind of like have a big shift over into digital pathology, that's potentially going to be even bigger than radiology, to be honest. So I'll be watching that very carefully. I think so. For procedural medicine, I think we're still at the tip of the iceberg in terms of robotic approaches to procedures. So I'll be watching that. I think, Vic, you mentioned, I think earlier, I think you alluded to NLP for clinic notes. I think that's something so NLP being natural language processing, your listeners probably are familiar with, but that's really kind of taken the world by storm right now. And again, it's one of those areas that it's low hanging fruit and it's real dollars and cents. If you can speed up the patient kind of throughput in a clinic, that's really, really important for a health system. And so I think we're going to see, greater adoption there. And then I think the final area that I'm really excited about in healthcare in AI is drug discovery, just kind of targeted drug discovery and for therapeutics, which is a little bit outside of my wheelhouse, but I still think all the same considerations that we talked about apply to that area. So yeah, that's kind of like the 12 to 18 month. Then you kind of get into like past the 18 months. And that's where, again, things start getting a little bit vague. And we start talking about multi-omic computational insights. We talk about predictive analytics. We talk about personalized medicine. I don't think anybody has really kind of figured out yet exactly what that looks like. And I'm actually curious to know what that looks like myself. And I'm actually curious to know I do think that there's a lot of hand waving going on about AI for for personalized medicine, and I don't know what it looks like yet. I'll be very excited to kind of hear a very, very concrete vision for what that looks like, because I haven't heard it yet. I was actually just in a conversation yesterday with someone. We were talking about primary care. And in a similar conversation to what we were having earlier, like private care, primary care roll up, we want to deploy technology, we want to use AI, but the only thing we've really seen in this area so far is AI for risk adjustment and charge capture and making sure that we have the right complexity score and we maximize our Medicare Advantage reimbursement, which is important. Really, really important. I totally think it's important, but it's not like curl your toes, like, wow, this is going to transform care. Important, and that's what I'm going to be looking for. And as soon as I find it, I'm going to jump in with, I'm going to dive in, because that will be really exciting once we can kind of really articulate what that looks like.
And do you think Europe is the place where these innovations are being tested and trialed, or is it all over the globe? What do you think? Where's the hotspot that we should be watching for?
Well, it's really all over the place. And, a friend of mine actually wrote a really, really provocative commentary article a couple of years ago where he suggested that as opposed to most areas in healthcare where innovation has happened in the rich developed countries and then kind of secondarily you kind of diffused down to the underdeveloped and underserved countries, he was actually suggesting that it may actually be the opposite in this case, that it actually may be the underserved areas of the globe that kind of receive the technology first, because there is such a shortage of physicians, because there is such a resource constraint, and because technology can be deployed so much like more easily, more quickly in underserved areas. And maybe that becomes the laboratory and testing ground. And then, from there, kind of following the reverse innovation funnel, like the most successful applications kind of become adopted in the more developed countries. I don't know, but I thought that was a very interesting kind of perspective on it, which I hadn't heard before.
Yeah, I think that's a good thesis. I mean, especially the autonomous version of AI. If you go to a country like India or Africa or so, where they don't have a lot of providers today, and the option is give no treatment or offer this autonomous AI, which is arguably better quality than human doctors, but it's at least, comparable, then you can start to get decent volume of how is it performing, and then introduce it in the right place in the developed world where there's a lot of doctors and we have the luxury of waiting to see. Maybe.
Yeah.
I mean, it's just like the proliferation of mobile phones.
Yeah.
In the developed world, right? I mean, it makes sense where there's a lack of infrastructure, but an appetite for innovation, and low regulatory barriers, then the technology can advance appropriately.
Yeah, and then we watch that and grab whatever is really working.
Yep.
I think that could be good. So, okay, Rick, I want to close with a couple months ago in March, you delivered the plenary address at the European Congress of Radiology, which is a fancy name, and titled Radiology, AI, and the Analog Digital Frontier. So it's a 20-minute presentation. We'll link to it in the show notes. I think a lot of our listeners would be interested in hearing the whole talk. And you sort of co-present it with an AI entity, which is pretty interesting. But I want to have you focus on, you end that talk with 6 recommendations for the radiology profession. And I wanted to see if you could talk through that with us. And then I think there's some transition to all healthcare professionals or investors or entrepreneurs could take pieces of these recommendations for themselves. So maybe let's talk through those 6 ideas that you closed with at the Congress.
Yeah, sure. See if I can remember them all.
I have them written down, so I can prompt you if you want. But the first was really define the problems that are in need of solutions when we combine humans and AI. That's sort of where it started.
Yeah, exactly. This was a fun talk to give. It's I think it's out on YouTube. You said you're going to link to it.
I'll link to it. It is on YouTube.
I think it's the first and only time that I'll interact with a 20-foot animated AI robot. So anyway, yeah. So the first one was defining the problems in need of solutions, and that was really it was really kind of like a recapitulation of what we talked about with the academic medical centers and this kind of history of some false starts, I think, in terms of applications being developed that don't really hit the mark, at least like it aren't really hitting the nail like squarely on the head in terms of what's needed. And so, there's a lot of developers out there, and this is kind of like to the folks out there who are the entrepreneurs and the developers in terms of, when they're trying to launch new ventures, to make sure that you get input from the end users, make sure that that you're talking with if they're clinicians, if they're administrators, whoever the end user is going to be, make sure that you do the upfront research and ideally incorporate these folks in the design process, so that you're actually defining a solution squarely in need of a pressing problem. I think the second one was about understanding how AI tools should be trained. And again, kind of working with developers to, there's different approaches to training these tools. There's different approaches to gathering data. You want to make sure that the data, it is appropriately reflective of the population you're going to serve. That's a big pitfall, I think, that a lot of developers miss, as well as knowing whether are you going to have supervised learning, unsupervised learning? Are you going to do an LLM approach? Are you going to do a more traditional kind of data science, machine learning approach, all of which is really part of that whole initial design process and making sure that you're really developing a solution with the end use case in mind.
Yeah, and sorry to interrupt, but the healthcare industry, I think you were speaking to radiologists, but the healthcare industry broadly needs to learn enough about AI to then contribute to how it should be trained. And then also you were talking about guardrails in the talk, like where should the guardrails be put in place? The clinicians and the healthcare administrators and even the regulators should learn enough to be able to have an intelligent conversation with the technologists in that space.
Exactly right. And a lot of people need to be involved in this conversation. I mean, not to get off on a tangent, but we all know that we have concerns about lack of transparency. We have concerns about privacy. We have concerns about bias. And drift in these algorithms. We have medical legal concerns. We got to get the lawyers involved at some point to help us understand, what are the implications if all of a sudden you have an autonomous, chest X-ray reader? What if there's a mistake? Who are you going to sue? Like all these things, these a lot of different folks, right, need to be involved in the conversation.
Yeah. Then three and four were work with regulators and policymakers, and then 4 was create independent data sets for testing and evaluation, which I think is a really valuable thing that the industry should do so that we bring the right data points in.
Exactly. And I think the conversation with policymakers and regulators is all about, walking that fine balance and making sure that we're keeping patients safe while also promoting access to cutting edge care. And regulators, that's the dance that they do. They're always walking that fine line. But we want to make sure that we're incentivizing innovation. We want to make sure that we're incentivizing development. But we don't want to go so fast that we miss the boat in terms of guaranteeing safety.
Yeah. The next was probably the most intriguing. Evolve our vocabulary to focus on long-term patient outcomes, which suggests to me that people in the audience maybe have a vocabulary that is not focused on that, which I was surprised about. But
I think so. This, I think, is a problem that's pervasive all throughout healthcare, and this is a soapbox that I could jump up and down on. But we all, especially in the scientific community, especially in the clinical science community, we have a tendency to adopt surrogate measures of performance, surrogate measures of success, because they're easy. In the AI world, it might be accuracy, for example. I'm going to do a study and I'm going to show that this tool is accurate for detecting, I don't know, fractures or something. And that's great. That's wonderful. But it's one thing to show that I'm accurate for fractures. It's another thing to show that the fact that I'm picking up the fracture actually is important long-term downstream to the health of the patient. It could be that that's actually just a tree falling in the forest and, nobody's really around to hear it. Maybe, it could be that I'm picking up on fractures that are so easy that I'm not making any kind of impact on clinical care whatsoever. Or it could be that I'm picking up on fractures that really aren't important because they're going to heal by themselves. So it's only if we talk about long-term downstream patient outcomes that we can calibrate ourselves to make sure that we're actually talking about things that are important. And that's true not only in radiology, it's every clinical discipline. It's clinical, it's non-clinical. We want to try to focus on what matters to patient at the very, very end of the day. And we could, again, talk for hours and days and weeks about this. But I know you're familiar with it, and it's important for investors as well. We want to talk about not what's important to the next quarter, but potentially what's important to the life and health of a company over the course of multiple years. It's the same mentality, and it's just applied very narrowly, in this case, to AI.
Mm-hmm. Yeah. And then you ended, and I think it's a good way to end our discussion. The last one is shape the role of the human radiologist to use AI and other valuable technology tools as the ultimate information integrator of the diagnostic ecosystem. So basically the radiologist would be integrating information from all types of tools, inclusive of AI. That's a pretty interesting role for the radiologist to become, I think, unless maybe I misunderstood what you were saying.
Yeah, well, I mean, and it is a great place to end because I think it's, as we look to the future, we all are going to have to redefine our own identities as professionals. And, that's true for healthcare. It's true for investors. It's true. I mean, it's true all over the place. With technology, our roles change because technology is in some places replacing what we do. In other places, it's augmenting what we do. In other places, it may make what we do completely irrelevant. So in radiology, I think the professional role, the professional identity of a radiologist is going to be quite different in 10 years than it is today. And I think radiology as a specialty needs to be comfortable with that and needs to embrace it and needs to get out on top of it instead of burying its head in the sand, right? And so, if you take a look, I'll just draw a historical example. So my father was a pathologist, so he worked in a pathology, worked in a hospital with a pathologist. Over the course of his lifetime, the identity, the role of a clinical pathologist was dramatically changed. It was nothing toward the end of his career like it was at the beginning. You look at clinical pathology, your clinical pathology, you're doing blood chemistries, you're looking at a microscope, you're doing blood analysis. All this stuff is stuff that was done by hand by the pathologist when my dad was starting out doing this. And by the end of his career, it's machines and technologists doing it. And it's not that the pathologist had no role there, but it was a different role. Like now, the role is supervising, calibrating the machines, performing quality assurance, making sure that the technologists are doing their job right. Is a totally different role, equally as important, maybe even more important, but very, very different. So, translate that over to radiology. Maybe in 10 years, the radiologist role, if we have an autonomous chest X-ray reading machine, for example, maybe the radiologist role is actually supervising and calibrating that machine and performing quality assurance and making sure that the communication protocols are set with the other physicians and making sure that the workflows are optimized. Very, very different role, requiring different skills, but still very, very important. And still, I think I would argue requiring, medical license, postgraduate training. It's not like all that stuff that stuff isn't irrelevant. It's just you're taking that same training and skills and you're applying it in a very different way, taking advantage of a technology-enabled environment. And so that's kind of what I was getting there too. And I think that's true for all of us, in medicine and elsewhere, being comfortable adapting to new technology and making sure that we can kind of redefine ourselves to make sure that we're maximally relevant in this brave new world.
Yeah, so I really liked it because I think it's optimistic, but also pretty honest about what the role's going to need to evolve into. And it's interesting to think about a radiologist because over your career, I'm sure there's been new imaging modalities that have come out or different uses of those modalities. So PET scan versus CT versus MRI versus X-ray. There's probably others. And your role becomes helping the physician and the patient decide which should we use, how do we interpret these, what's the right use case, how do we calibrate the machines, what slice should we take. All those things are as important as the reading of the particular image. And it's an evolution that I think is framed really optimistically for radiologists, and I think we can translate it to other domains. They'll have to use lots of tools, including AI and other technologies, but the medical expert, the doctor, is still going to need to be the empathetic caregiver that's sort of advising the patient on which tool to use, in what form, and for what purpose, and with that whole long-term patient care as the overarching goal.
Absolutely, 100%. Couldn't agree more. And I won't go into that part where that research showed that ChatGPT is more empathetic than doctors. We won't mention that.
Yeah, I think once we free up doctors' time, they will become very empathetic. That's my optimistic.
There we go. I like it. I like the optimism.
Yeah, Rick. Anything else that we didn't cover that we should have?
Oh, this has been great. No, I think this has been a great conversation. I really enjoyed it. Thanks so much for having me on. It's been a pleasure.
Yeah, excellent. Well, thanks for your time. Really appreciate it. And we'll keep following this. We may have you back as we get new progress.
Thanks, guys. It might be a robot next time, but okay.
Thanks, Rick. Right.